Advanced Psychology, Atypical Behaviour. Explanations and therapies for anxiety disorders. Biological approach. Biochemistry. The brain produces chemicals to pass messages between neurons in the nervous system. These substances are known as neurotransmitters. Scientists have considered the possible role of the neurotransmitter gamma-aminobutyric acid, GABA. When you are faced with a frightening event, such as a car accident, neurons throughout the brain fire and create the experience of anxiety. In normal anxiety, the neural firing sets off the production of GABA to slow down neural activity. This ensures that the anxiety subsides. Someone with an anxiety disorder may have a defect in his or her GABA system, which means anxiety is not brought under control. Anxiety disorders may result from too little GABA in the brain. Evaluative comment. Brain chemistry may provide a possible explanation for some anxiety disorders, such as general anxiety disorder, GAD. Others, like specific type phobia, are less convincingly explained by this approach. In specific phobias, one particular stimulus alone provokes an unusual anxiety response. The rest of the time, the individual responds normally to stressful situations. Biological treatments. Sedatives or tranquilizers have been developed to reduce anxiety. They are known as anxiolytic drugs and are among the most widely prescribed drugs. Sane, 2002. Barbiturates were the first major category of drugs used to treat anxiety. Because they were life-threatening if someone took an overdose, they have been largely replaced by benzodiazepines. This group of anxiolytic drugs is known to affect GABA neurotransmitters in the brain. They reduce anxiety by enhancing the release of GABA. More recently, drugs that were originally developed to treat depression have become popular in treating anxiety disorders, in particular OCD and social phobia. Antidepressants such as Prozac are prescribed. This highlights that depression may be an important component of an anxiety disorder. Evaluative comment. A major problem with anxiolytic drugs is that they are addictive. Patients can develop dependency, making withdrawal symptoms likely. Herbert, 1995. Also, the anxiety disorder can return if the patient stops taking medication. This is because biological treatments control the symptoms of anxiety but do not address the cause. Other more psychological approaches to anxiety, such as cognitive or psychodynamic psychotherapy, attempt to alleviate symptoms and understand where the anxiety comes from. Genetics. There is some evidence of a genetic vulnerability to developing anxiety disorders. Study 1. The aim. Slater and Shields, 1969, investigated the role of heredity in anxiety disorders. Method. They examined 17 pairs of identical twins and 28 non-identical twins, where one twin had been diagnosed with an anxiety disorder. Slater and Shields wanted to know if the other, or co-twin, also had an anxiety disorder. As identical twins share 100% of their genes, it was expected that they would have very similar psychological functioning. This similarity is called a concordance rate. A lower concordance rate was expected for DZ twins because they only share 50% of their genes. Result. A total of 49% of the MZ co-twins were also diagnosed as having an anxiety disorder. In the DZ twins, as expected, the concordance rate was lower, at 4%. Conclusion. The study provides some evidence for the role of genetics in the development of anxiety disorders. Evaluative comment. Evolutionary psychologists like Hugdahl and Oman, Hugdahl et al., 1977, argue that some phobias, such as a fear of snakes, do have a genetic component. They believe people react negatively to certain animals because they were sources of danger in our evolutionary past. However, while Slater and Shields' study does provide evidence that genetic factors are implicated in anxiety, if it were a wholly genetic disorder, the concordance rate for MZ twins should be 100% and for DZ twins 50%. Other factors must be involved to make the affected twin more vulnerable or protect the non-affected twin. Also, the sample size was very small and not representative of the population as a whole. Finally, while research into the role of genetics is ongoing, the approach does not as yet provide a method of treatment. Psychodynamic approach. Freud, 1909, believed there are two types of anxiety. Objective anxiety, or realistic anxiety, is caused by an external event. It can often be dealt with in a rational way. For example, worry about a driving test can be overcome by booking more driving lessons. With this type of anxiety, there is an environmental cause and it is reasonable to feel anxious. Neurotic anxiety is caused by internal psychological, or entraps. Why-chic conflict. It is the result of the early power struggles between parent and child as the child's personality forms. Freud thought that personality developed in stages and consisted of 3 parts. See Chapter 1 in Introducing Psychology. The id, which you are born with, is an unconscious part of the personality and is composed of sexual and aggressive instincts. The ego develops in early childhood to keep these basic instincts in check. Freud thought that during this time, parents punish the young child whenever it fails to control sexual or aggressive desires. The child's wishes are often in conflict with adult expectations, creating tension and distress. To reduce the conflict, these painful encounters with adults are repressed, kept from conscious awareness. In adulthood, neurotic anxiety occurs when a person is faced with a situation that unconsciously reminds them of this repressed conflict. It represents the fear of the consequences of expressing the id-driven impulses. Neurotic anxiety is dealt with through an unconscious distortion of reality by means of defense mechanisms. These allow the ego to discharge some id energy, sexual or aggressive, without facing up to its true nature. In effect, defense mechanisms are a disguised outlet for basic desires. Evaluative comment: this approach is very subjective, as perhaps you have discovered. It is possible to interpret the same symptoms in different ways. Critics of Freudian theory argue that it is culturally specific. At the time Freud was practicing, during the reign of Queen Victoria, expression of sexual desire was seen as distasteful. Freud developed his theories in a culture of repression. Today, however, sexual desires are much more openly acknowledged. In spite of increased liberalism, there had been no significant reduction in people with anxiety disorders. This implies that anxiety is not solely caused by repressed sexual instincts. Psychodynamic treatment: Freud was one of the first practitioners to develop and use psychotherapy. Psychotherapy is a social interaction in which a trained professional tries to help another person feel differently. There are now many different types of psychotherapy. The psychodynamic approach assumes that the patient, or client, does not understand what motivates them. The therapy aims to help people gain insight into why they behave, feel and think the way they do. The therapist analyzes what the patient says, to uncover the hidden, unconscious cause of neurotic anxiety. Clients are encouraged to talk about whatever comes into their mind without interruption. This is known as free association. During free association, the client's ego will try to protect itself from any threat of the id emerging, using defense mechanisms. The therapist analyzes the latent, hidden, meaning of these defenses to help the client gain insight. The client's dreams are also examined for evidence of symbolic representations of repressed childhood conflict. These interpretations are explained to the client, to help them make sense of the true cause of their distress. Freud believed insight helped clients to gain greater control of their emotions and reduced neurotic anxiety. Study 2. The aim. Freud wanted to help a friend's young son, Little Hans, to recover from a phobia of horses. Method. Freud asked the child's father to send him details of the phobia by letter to enable him to uncover the underlying cause. The father told Freud that Little Hans was afraid of large white horses with black blinkers and black around the mouth. He had become terrified to leave the house and was very anxious that a horse might bite him or would fall down. Freud made an analysis of this information. Result. Freud interpreted the phobia as the conscious representation of the Oedipus complex. At around 5 years of age, Freud believed that a male child desired his mother in a sexual way and perceived his father as a rival. The boy feared that the father would discover his desires and castrate him. Consequently, the boy unconsciously wanted his father to die. For Little Hans, the white horse symbolized his father, who wore glasses, the horse had blinkers, and had a moustache, the horse was black around the mouth. Fear of being bitten by the horse represented castration anxiety, whilst fear of a horse falling down was his unconscious wish to see his father dead. Conclusion. Phobias are caused by neurotic anxiety and are linked to repressed childhood experiences. Evaluative comment. Supporting evidence for Freudian theory is restricted to reports of case studies undertaken with a small sample of patients. In the case of Little Hans, Freud only met his patient once and relied mainly on correspondence from the boy's father. As Little Hans had witnessed a horse collapse and die in the street, the phobia could have been a learned response, rather than an unconscious Oedipal desire. We will examine this more behaviorist explanation later in the chapter. It is possible that Freud's adult patients, who were mainly well-educated and middle class, were aware of his interest in certain topics. This may have affected their perspective, causing them to focus on childhood conflicts and sexuality during therapy, and to overlook other more important events. The behaviorist approach. The behaviorist approach focuses on the idea that anxiety is a learned response. Individuals associate fear with a neutral stimulus through a process of classical conditioning. Alternatively, anxiety may develop because the response is reinforced, or rewarded, in some way. This is known as operant conditioning. Study 3. The aim. Watson and Rayner, 1920, wanted to show how a phobia could be learned. Method. A 9-month-old baby, known as Albert, was tested for fear reaction to a number of stimuli, including a white rat, a rabbit, some cotton wool and a hammer hitting a steel bar just behind his head. Only the loud noise frightened him. Watson and Rayner then presented the rat to Albert and allowed him to stroke it. Whilst he was playing with the rat, Watson hit the hammer on the steel bar behind his head and frightened him. Result. After several pairings of the two stimuli, Albert developed a phobic response to the rat. He was fearful even when it was presented without the loud noise. Conclusion. Phobias are learned through a process of classical conditioning. Two-process theory. Mora, 1939, believed that there were two behavioral processes involved in anxiety disorders. First, the acquisition of fear is brought about by classical conditioning. Second, through a process of operant conditioning, the avoidance behavior is maintained. By staying away from the feared object, anxiety levels drop. Avoidance behavior is therefore positively reinforcing. For example, people with agoraphobia may have experienced a panic attack in a public place. They associate going out with a high level of anxiety and start to avoid it. This behavior keeps their anxiety at an acceptable level, and so avoidance is rewarding. By staying in, they reduce the likelihood of learning a new response, and so the phobia continues. Anxiety levels are kept at manageable levels by the avoidance behavior. Evaluative comment. In Watson and Rayner's study, the fear response was conditioned over several trials. In the real world, it is unlikely that two stimuli would be so systematically paired to produce the phobia. Later attempts to replicate Watson and Rayner's experiment have not been successful. For example, Davison, 1968, found that humans could not be classically conditioned to fear neutral stimuli, even when they were paired repeatedly with a painful electric shock. Many phobic patients cannot remember unpleasant experiences with their feared stimulus. Conversely, many people have had unpleasant experiences and yet not developed a phobic response. For example, frightening events often happen in cars, such as near misses, emergency stops or traffic accidents. However, cars are not a common object of specific phobias. Behaviorist treatments. Behaviorist treatments are much less concerned about the underlying causes of the disorder than psychodynamic treatments, concentrating instead on helping the person learn new responses or behaviors to the things that make them anxious. Study 4. The aim. Jones, 1924, wanted to show how a phobia could be successfully treated using behaviorist techniques. Method. He worked with Peter, a 2-year-old boy who was frightened of a number of things, including rabbits. Jones put a rabbit in a cage in front of Peter while he was eating his lunch. Over 17 steps, the rabbit was brought closer to Peter, set free in the room, and eventually sat on Peter's lunch tray. Result. Peter was no longer frightened of the rabbit. Conclusion. Classical conditioning can be successfully used to treat phobias. The process used by Jones, 1924, is known as systematic desensitization. Behavior therapists work with clients suffering from a variety of anxiety disorders to help them slowly and systematically overcome their anxiety. The first step is to teach the client relaxation techniques such as deep breathing. The therapist also educates the client about the body's stress response. For example, advising them that the human body works automatically to bring symptoms of anxiety under control. If the client experiences anxiety, they should wait for a few minutes to allow it to subside. The client then works with the therapist to draw up a hierarchy of anxiety-provoking events. This is a list of situations ranked from most difficult to cope with, down to least difficult. For example, a client with obsessive-compulsive disorder who is fearful of contamination and washes compulsively might find gardening very stressful. Watching television might be the least stressful activity. The client is then asked to imagine being in these situations, starting with the least stressful. If they experience any anxiety during this process, they are asked to use their newly developed relaxation techniques or simply to wait for the feeling to disappear. The approach works through classical conditioning. The client is learning to associate a new response with a previously distressing stimulus. Eventually, the client will be asked to experience the situations in real life. For the technique to be successful, the steps to recovery should be moderately challenging yet achievable. Evaluative comment. Behavior therapy can be very useful in treating anxiety, but the client must be highly motivated to change and prepared to experience stressful situations. Many anxious people would find the regime too difficult to maintain. The behaviorist approach doesn't look for underlying causes, and tends to focus on behavior rather than thoughts and feelings. However, it has been successfully combined with cognitive approaches to create a new treatment method called cognitive behavior therapy, CBT. The cognitive approach. The cognitive theory of anxiety suggests that people become anxious because of their negative beliefs about themselves and the world. They have a tendency to perceive non-threatening situations as dangerous and anxiety-provoking. Clark, in Horton et al., 1989, called this catastrophic misinterpretation. For example, if you were talking with your friends and one of them yawned, you would probably conclude they'd had a late night. A person with an anxiety disorder is likely to interpret the same event very differently. For example, they might think, "I'm boring and everybody hates me." They perceive an ordinary event as if it had terrible consequences. This creates or adds to any existing feelings of anxiety. Study 5. The aim. Yoon et al., 1997, wanted to investigate the role of cognitive processes in anxiety disorders. In particular, they wanted to find out how anxious patients interpreted the physical symptoms of anxiety. Method. They used questionnaires to measure and compare the interpretation of the physical symptoms of stress in 3 groups of participants. Group 1 consisted of participants suffering from anxiety disorders. Group 2 consisted of participants suffering from depression. Group 3 was a control group, with no psychological difficulties. Result. They found that those in the anxious group were more likely to interpret the physical symptoms of anxiety, such as an increased heart rate, as dangerous and life-threatening than the other groups. Worries about the social consequences of the physical symptoms, such as embarrassment, were found in both the anxious and depressed groups. Conclusion. Negative thoughts about the physical symptoms of stress play an important role in the onset and maintenance of anxiety disorders. Both depressed and anxious participants have greater concerns about what others think about them than a control group. Evaluative comment. The cognitive approach concentrates on the negative thought processes that are evident in people with anxiety disorders. However, it is not particularly interested in what causes someone to think in this way. The approach also concentrates on the internal cognition of an individual, without taking into account any social or environmental factors. For example, King et al., 1999, found that people were less likely to suffer from post-traumatic stress disorder after a major trauma if they had a high level of social support available to them. Thought processes may be influenced by how much help is available to you. Cognitive treatments. Cognitive therapy concentrates on the negative thought processes of an anxious individual and aims to directly challenge and change these catastrophic misrepresentations. First, the therapist will educate the client about the relationship between thought, feelings, and behavior. Beck et al., 1979, gave examples of how to achieve this. Clients are asked to imagine a person who heard a crash in another room, while alone in a house. The client is asked the following questions. 1. If the person thinks, "That must be a burglar," how would they feel and behave? 2. If the person thinks, "The window is open and the wind has blown something over," how would they feel and behave? Clients should start to understand that negative thinking contributes to the anxiety disorder. If the client thinks in a positive way, they will feel and behave differently. The client may also be taught a variety of distraction techniques to help them manage negative thoughts. Clark, in Horton et al., 1989. A series of questions, like the examples below, can also be used to help the client evaluate negative thoughts and replace them with more realistic ones. 1. What evidence do I have for this idea? 2. How would someone else think about the situation? 3. Are my judgments based on how I feel rather than what is happening? 4. What if it happens? So what? Towards the end of the therapy, the emphasis will move away from reducing the symptoms of anxiety, and towards maintaining the new ideas and thought processes. Clients may be asked to anticipate future setbacks and plan how they will overcome them. Evaluative comment. Clark found that cognitive therapy was highly effective in the treatment of anxiety, particularly for patients prone to catastrophic misinterpretation of bodily symptoms such as increased heart rate. Many practitioners combine the cognitive and behavioral approaches to help the patient change both thoughts and behavior. However, as with any talking cure, the client must be quite articulate and be prepared to be challenged by the therapist. Clark, in Horton et al., 1989, acknowledges that it is sometimes difficult for anxious patients to identify their negative thoughts. Effectiveness of treatments for anxiety. As we have seen, there are different explanations and treatments for anxiety disorders. The behaviorist approach has been successful in treating patients with anxiety. Salkovis and Kirk, in Horton et al., 1989, claim a 75% improvement rate in the treatment of obsessive-compulsive disorder by exposure techniques such as systematic desensitization. However, treatment refusal and dropout rates are also high, up to 50% of those patients seeking help. This led Salkovis to recommend a combination of cognitive techniques with behavioral treatments. A collaborative relationship between the therapist and patient can be developed using a cognitive approach. This has been found to reduce treatment refusal. Whilst drug treatments have been effective in reducing the symptoms of anxiety, Marks, 1987, found a high incidence of troublesome side effects. Also, when patients stop taking the medication, the symptoms may return. However, combining medication with behavioral techniques has been successful, because it helps the patient to feel more confident during exposure to anxiety-provoking situations. Garfield, 1980, reported that psychodynamic therapies are effective with well-educated, strongly motivated and confident people, suffering from light to moderate difficulties with anxiety. Researchers call this the YAVIS effect, since such people tend to be young, attractive, verbal, intelligent and successful. Some psychologists, such as Beitman et al., 1989, would argue that any effective therapy must be responsive to the individual client's needs. An experienced mental health care practitioner would tailor treatment methods to suit an individual patient. For example, a patient who had GAD might be offered a course of anxiolytic drugs and cognitive therapy.